And good evening, everyone. It's Dr. Bill Tullo, Medical Director of Oculus, and welcome to the Oculus series of webinars. Tonight, we have Mastering Myopia with Oculus Diagnostics and WAVE Customized Ortho-K lenses. Before I introduce our speakers, a little housekeeping. I want to make sure everyone knows to enter questions into the chat, and we'll leave some time at the end to try to answer all your questions. If there are too many questions, we will answer them via email. Tonight's speakers, I'm really excited to hear this talk. We have two speakers tonight, Dr. Michelle Chung. Michelle Chung graduated from Pennsylvania College of Optometry and currently practices at the Eye Academy in Toronto, Canada. She's also a part-time clinical lab consultant with WAVE. Dr. Chung specializes in specialty contact lens fittings such as scleral lens or corneal RGPs for patients with conditions that present any type of corneal irregularities. And our co-speaker, Dr. Stephanie Ramdass, is in private practice in Ontario, Canada. She graduated from the Inter-American University of Puerto Rico School of Optometry and completed a cornea and contact lens residency at the Michigan College of Optometry. She's contributing author and editor for Contact Lens Spectrum and Clinical Refractive Optometry, a committee member and contributing author for the International Myopia Institute, and a Canadian MIP Research Principal Investigator. With no further ado, I want to introduce our speakers tonight, Dr. Chung and Dr. Ramdass. Take it away, ladies.
Thank you, Dr. Tullo, for that introduction. I am Dr. Stephanie Ramdass. I'm here tonight to present to you all with Dr. Michelle Chung. We want to have kind of a conversation back and forth between Dr. Chung and myself. We will be touching upon myopia management aspects, focusing on some practice management tips, going through the diagnosis process, and then straight into some software customized designs for Ortho-K specifically. So we'll be using kind of a variety of different teaching aspects during tonight's presentation. Here are our disclosures. And so when opening, the cold start practice that was opened up that I currently am the director of is called Academy, and it was a cold start practice in 2021, at which point the goal, just a little bit background about myself, I worked at the Optometry School in Michigan for 5 years, where we, I can't say I'm a recent grad, so I'm a grad from 2013. And at that time, we were really strongly getting into myopia management at the university. And so I wanted to definitely bring some of that back here to Canada. Little to be known going forward, Canada has kind of a vast array of myopia management options. So there are a lot of patients that come in either versed in what myopia management is and what options there are, but there's still a significant portion of the population that has no idea. So there's a lot of patients to educate and bring awareness to. So specifically finding, I mean, if you're in practice and you have a breadth of patients already at your disposal, I bet you, if you take a look at the last week of patients, maybe of the last month of patients, if you're not already incorporating myopia management into practice, perhaps you could even find patients that are worth initiating some form of treatment or starting the discussion of myopia management. So you don't really have to look far. I had to do a little bit of work in the sense that we had to use methods such as social media, creating, Zoom, essentially webinars between myself and parents, for example, where they would ask questions as to whether or not their child is eligible for a type of myopia management treatment. What is myopia? What types of treatments are out there? How long do they need to have the treatment for? So there's a lot of questions to be asked. And I think, just taking, if any of you are hesitant to get your feet wet when it comes to myopia management, just, treat a handful of patients, like 3 to 5 patients, do it well, follow up with them, and then kind of word of mouth tends to extend. To the extent that we have now a referral base where other optometrists refer to our office. We can, both Dr. Chung and myself work at separate practices as well, so we can self-refer into the practice. There are patients that come from outside of the country because we have different options available to us here. So it takes a little bit of time to build it if you don't already have the patient base, but it is a well worth value. Plus, it's now standard of care to be treating our myopia management patients, not just correcting them. And so it's the time to kind of spread the word on managing myopia. One of the things that I think is valuable to a myopia management consultation visit and that's valuable to a treatment plan, or initiating a treatment plan, that is to have a dedicated time to talk about what your child's myopia level means to them at that particular age. If you bring it all in a baseline exam, I've been, kind of flagged for this, where there was a language barrier between myself and a parent of the patient. And I tried to, show with my little sketchboard what the eye is doing, how the eye is elongating, how they're outside their age-expected norms. Mom panicked, she started crying, the child panicked, and they just kind of walked out of the room. So I'll never do that again. And so to take time to discuss, maybe confirm the baseline findings during a regular eye exam where you diagnose myopia, and then, do your certain diagnostic tests that help build kind of the case as to why this patient might benefit from a myopia management form of treatment. So specifically, in order to build your case, while you don't need tools to, other than showing a refractive error change, let's say, for example, or maybe uncovering myopia for the first time and seeing that you're outside of an age-expected norm, I am a strong believer of having metrics to properly monitor patients over time. We're focusing today on Ortho-K, and so because we're not necessarily checking for changes in refraction over time, axial length really is the gold standard for an Ortho-K based patient to assess whether or not the form of treatment is being maintained and you're holding true to what that patient should be achieving for a myopia management program. Well, of course, with Ortho-K, we're not looking to completely stop or halt the progression of myopia. I mean, in the cases that we get, that's great, but we need to determine over time if we need to make changes to the treatment protocol that we have going on. Obviously, in that dedicated time for a consultation visit, you can confirm your baseline RX, cycloplegia a patient if necessary. Consider not just the refractive and age of the patient, but how is their social environment? Do they have parents that are myopic? Do they have siblings that are myopic? And then kind of give an overall, not necessarily like a percentage of risk, but overall, where does the patient lie? Are they at a mild risk for long-term irreversible vision loss? Are they at a high risk for long-term irreversible vision loss? And that helps put things in perspective with the parents. So what types of diagnostics are we looking for? I do find that visuals, I mentioned earlier about having kind of a sketchboard to show how the eye is elongating. Taking it one step further, I think it's really important to bring up the discussion of axial length and kind of where that patient lies in relation to what the average population is. So here, for example, are some printouts, some screenshots from the Myopia Master device that actually is able to measure the axial length. In this particular case, you can see we have measurements for the right eye, and in the blues in the left eye. It plots out a spherical refractive error along the right y-axis, and on the left y-axis is the axial length. Great aspect for us to see how the patient progresses over time. I always like to get a baseline finding and determine with the parent if that patient is at the point where they need to make some sort of adjustment in their spectacles. Is single vision spectacles cutting it for this patient, or do we need to do something else? You can also take measurements sequentially over time, as I'll show you in later slides. So it's a great way to also hold information over time and show patients how they progressed either in the lack of treatment or the current treatment program that they're on. It's always important to, like I said, bring together the different aspects of a patient's, not just kind of genetic aspects, but social aspects as well. Are they spending time outdoors? Do they have, less than an hour a day, or, greater than 10 hours a week? If that's the case, then that puts them in a different risk profile from somebody who would be spending less or more time outdoors. Are they, studying hard every day, or are they spending a good amount of time away from screens? All of these play a role in the potential need to treat a little bit faster, maybe treat a little bit aggressively. And then in the evaluation portion of the Myopia Master, you can actually kind of check off different aspects. If we discuss soft multifocals, or if we discuss contact lenses, for example, we can check off different boxes and change the percentage if wanted to cater to our particular patient. This can be printed out. It's a great take home for your parents, or you can even just save it to a PDF and you can email a report to them as well. So it's a good email follow-up if they aren't sure about managing myopia. I do find that following up with parents is really important. So I like to present all options. Obviously, correcting myopia with Ortho-K or glasses is, what we do every day. We can correct the vision, but to treat the myopia is really where a lot of the technologies lie that we have presented to us here. I do, like I said, know that in Canada, we've been kind of blessed and a little bit spoiled in all the options we get, but tonight Dr. Chung and I will be focusing on Ortho-K specifically to slow down the progression of myopia in our kids. So specifically when it comes to Ortho-K, what barriers do I find to initiate treatment? I mean, I look at the child that's presented in front of me. Are they, screaming and running across the room, or are they, paying attention to some of the aspects that I'm saying? Are they listening while the parent is listening as well? I find that the biggest aspects with starting a myopia management program is compliance, regardless of what treatment type you use. And if the parent and the child are aligned, that also can help us have a better outcome for the child. A lot of parents that have kids that are in extracurriculars, I have kids that are looking, 5 days a week, they're in figure skating, or they're in tennis, or some other hockey. I have some of my patients in. It really does provide them with a competitive advantage to be in an Ortho-K program. And so I do find that those patients and parents tend to want to put their kids in a daytime contact lens free environment. If we're going to move to Ortho-K, do these kids brush their teeth every day? Do they make their bed every day? So it's not necessarily, can a 5-year-old wear contact? It's more so, do I feel the parent and the child together can put the child in a safe scenario where they can successfully wear contact lenses? Certain scenarios where parents are in 2 different locations, for example, and a kid is jumping between 2 homes, that can happen. You want to make sure that a child has an adequate amount of supply with them and the equal amount of supply. And of course, you're always going to face the safety profile of Ortho-K on eye. We know that wearing Ortho-K, the risks associated with microbial keratitis, for example, are no different than daytime wear of soft contact lenses. And they are safer to be worn overnight than a soft contact lens. So that is something I always like to reiterate to my parents. And if kid has any allergies or eczema, for example, you want to be able to treat any type of ocular surface disease or anything that's going to affect that patient's outcome with contact lenses. I'm not going to get too much in the finances, but that can be a barrier to treat. And so we provide the most important and the most safe and effective way to slow down the progression, and we allow the families to come to the decision of what's best for them. So once we've decided we're going to go into Ortho-K, Dr. Chung, what are some of the things that we need in order to be successful at fitting Ortho-K?
Well, there's many different ways of fitting Ortho-K, but tonight we're going to specialize or kind of focus in on the WAVE Ortho-K, the night lens design. So, if for those of you that are familiar with WAVE, we do not have a diagnostic set. Rather, they are more a software-based scan that generates a lens for you personalized to your patient. So since the WAVE software takes the topography reading and it generates a computerized lens, it's crucial that the topography is as close to perfect as can be. With missing data and artifacts, WAVE will extrapolate those data points and generate a lens that ends up being either too steep or too flat for the eye. And that's why when designing your initial lens here, you want to make sure you have the best topography that you can get, and this will just prevent your unnecessary headaches and excessive lens exchanges, which can ultimately frustrate both you and your patient. So if we see here, we have the different zones of the lens, which corresponds to the different areas where it's going to sit on the eye. If we look at this topography here, we can see that the superior inferior lashes and lids are both in the way, and it's obstructing that area from the topography being taken. So we kind of look at that, we're missing about close to 50% of the data for the lenses. Now, for a general diagnostic lens, this wouldn't be too much of an issue, but with WAVE, it's taking that measurement. So now it's gonna have to extrapolate all that data for it, and that could result into a lens that, you know, might not be the perfect first lens for your patient. So you'll probably have to go through many more iterations to get it perfect, instead of just going back and taking another topography by taking those lids and lashes out of the way. So let's take a look at another one here. So is this a good scan? Ultimately, we want that analyzed area to be about 85% or more, and here we have 95%, so that's a check. And we want vertical coverage, ideally 7 millimeters, but the more you can get, the better, the less extrapolated data there would be. So overall, yes, this is a very, very good scan. So for lenses like these, you'll probably get a pretty good first lens success, as long as they're a more easy case in terms of candidacy. So just some clinical pearls in terms of taking that topography. We want to keep the patient blinking. We want to get all the lids and lashes out of the way, using artificial tears if necessary, but also watch out for that lacrimal tear lake or that excessive pooling inferiorly. This is true for both your tear film dependent topography and your tear film independent topography. And then, as always, take a few topographies for baseline. That way, you know, if one of them ends up being not up to your standards, at least you have other ones to kind of go off of. So let's go through some cases, because I feel that's the easiest way to convey how the night lens works here. So we have a 12-year-old male, and his prescription is continuing to increase, but he always breaks his glasses. So, you know, we offered the parents to do orthokeratology as a method of control, and they were very interested. So his manifest was -3, -150 at 5, and then his left eye was -375, 150, 180. I just have a few other points here, which I'll kind of tie into after. HVID was, you know, relatively normal, 11.3, 11.2. So our goal here is to slow that myopic progression, and the patient's goal here is not to wear glasses during the daytime. So 2 questions we want to ask ourselves: is this patient a good candidate? And also, did we get a good topography, especially if we're fitting him into the WAVE night lens? So just as a general kind of for myself, and also like maybe for you guys, how I kind of differentiate my cases is between the 3 spectacle RX, the eccentricity, a little bit of astigmatism, and then flat Ks. So I differentiate them into easy, moderate, and challenging cases. So we can see here for this patient specifically, he was around a -3. So, you know, he's right on that cusp of the green to the yellow. And then same with the left eye, he was around a 375. So he's more in the yellow. So given the values that the eye had, I would say this is more so of a moderate case. So this means I would have to set the patient's expectations. I have to tell the patients and the parents that, you know, it might not be possible to correct all the way down to 20/20, but we can definitely try to achieve the best vision. And that, you know, they should still have a chance in trying the Ortho-Ks if they want a glasses-free option. But they might still have to wear either soft contacts or glasses throughout the day if we can't treat all of that prescription. So right here, we just have some of their baseline topographies. Like I said here, the left eye, we can see that there is poor vertical coverage. There is good tear film and good horizontal coverage, but if we could have gotten a better one on the left eye, that would have been better, but this is the best ones we can get. So we proceeded to make a lens. So this was the right eye design. I do like to lift my alignment zone a little bit. I'll kind of point out the zones a little bit later. This was the parameters of the right lens. And then this was my left lens design, looked pretty similar to the right lens. And then this is the parameters for that. So for the follow-up, the patient said the vision was a blurry, but better after 2.5 weeks of wear. So we did see him on the one-day follow-up. I didn't get any of the scans from there, so we'll just kind of skip it over. But we did have the patient wear it for another 2.5 weeks, and then they came back. Vision was not terrible. They were 20/40 unaided with each eye, and then we can see that they still had a little bit of manifest refraction. Here we see, even with lenses on, they still had a little bit of a minus refraction. So that, you know, kind of makes me think about a base curve change, even initially, even if the fit is not perfect, just to get those lens on VAs to be either plano or in the plus direction. So here we have some fluorescein patterns. The right eye seems to be a little bit decentered and pooling centrally. We can see that the lens is a little bit rotated because that dot is on the 6, that's supposed to be on the 6 o'clock, is up at the 9 o'clock mark. And then left eye, the edges look good. There's no rotation, but there's also that central pooling. So just a little bit talk about the WAVE software. When I talk about the reverse zone, I'm referring to the blue dots. The red dots is in charge of base curve or optic zone, depending which direction you go. And then the pink dots are for the alignment zone. So the best way to see how the lens is working on eye is to do a difference map in the tangential power. So here we can see, you know, relatively we have good treatment. Everything is generally centered. So I'm not worried about that mild decentration seen on the fluorescein pattern. But we can see that there's a poor reverse zone. We don't get a good red ring of treatment there, and then a very small central treatment zone. Left eye looks a bit better, which kind of corresponds to how our fluorescein pattern looks. But same thing here, we have a little bit of that central pooling previously, and that's probably what's causing the lack of suction and squeeze film forces here. So the issue here is under correction. And then also the fit of the lens. So the fluorescein pattern appears to be pooling centrally for both eyes and maybe a little bit decentered downwards for the right eye if we're being good nitpicky. Difference map, like we just said, poor reverse zone. It's centered and it has a good alignment zone. Same with the left eye, except the reverse zone is just a little bit better in that left eye here. So solution, we want to work from the outside end of the lens. We want to keep the alignment zone as is because it looked perfect on the eye, so we're not going to touch the alignment zone. But we do want to decrease that sag in the reverse zone because it has too much pooling causing central pooling there. So we want to decrease that sag there. And then just because, like I said, with the lenses on, there was a minus over refraction, we want to just flatten that base curve. Usually I reserve my base curve for a later modification, but in this case, I think it's warranted. So here we have our right eye. We can see here that although there's no pooling here, but on eye there was. So we're just going to go make that modification based off of the fluorescein pattern mostly. We want to decrease the sag in the reverse zone because there was significant pooling. I'm going to decrease it by 10 microns here. You see that it moved my alignment zone, and I don't want that because I was happy with where my alignment zone was previously. So I'm just going to go back in and increase that sag over there by the same amount I decreased the reverse zone. So we can see that came back down. And then the last thing we wanted to change here was the base curve. So we want to go back in here, change the base curve, and flatten it by the amount we wanted, which was 0.5. And then we just apply. So we see that how we easily went in to do those modifications, and then later on in this lecture we'll show you how to initially design a lens, but here we saw how fast it was to make those modifications. We're just going to quickly run through the left eye as well here. So same thing here. We see that there's no pooling here, but there was also pooling in the fluorescein pattern. So we just go back in here and we do the very similar modifications as the right eye. So first one, we want to do the reverse zone. we want to also decrease the sag there. And then we can either do 5 or 10. Here, we can do 10. If you feel like you don't want as much, you can always go back in and change it manually. So same thing here. We like the alignment zone where it was. So we want to go back in and just increase the sag there as needed. And then the last thing we wanted to change here is the base curve, just because of the minus over refraction with the lenses on. We want that to be either plano or closer to a plus over refraction. So we flatten the base curve here by a 1. And then we click apply. And just in those 1 minute, 30 seconds, we were able to modify both the lenses, and then we can send it out to the lab for them to send us the new lenses we want. So 2 weeks later, the patient comes back with the new lenses. It looks much, much better. We got rid of most of that pooling in the reverse zone. Alignment zone looks about the same. There was still a little bit of rotation in the right eye, but because their vision was pretty good, we kind of just left it at that. So unaided VAs was 2025 and in both eyes, but with both eyes, we were 2020, so the patients were very, very happy. Manifest lenses off was in the plus. The reason they're getting a little bit of prescription is that uncorrected cylinder that we didn't do. We could go in with WAVE and correct that cylinder, but usually if the patient is happy and not bothered by it, we won't fix it at this time. So takeaway here, by fixing the fit of the lens, we were able to take care of a lot of the undercorrection and the undercorrected cylinder here. And together with a small base curve change, the patient ended up being very, very happy. So I'll let Dr. Ramdass walk you all through a more challenging case now. Okay. Dr. Ramdass, you're still muted.
Yep, I'm here. Thanks, Asha. So this case, how you introduced the parents together, they decided that you wanted to proceed with myopia control, specifically with Ortho-K. This patient here, the mom came in very much knowing exactly what she wanted for her child. 7-year-old patient presented, she was a referral actually. She already had been in a diagnostic base Ortho-K design. And she was also using adjunctive therapy. She was using Ortho-K. So at that point in time, I did have some indication of what her pre-treatment was, but it wasn't until that we washed her out. And you can see that the current VAs with the lens design of choice was not adequate. And so the referral came in to see if there was anything else we could do to take it one step further and see if we can increase the level of acuity. At the time, she was using a residual spectacle RX, and you can see the VAs that were achieved with that residual spectacle RX. Sorry, that should be a -1, -1.25 for the right eye. So once washed out, it took about 3 weeks that we had her continue with her atropine. But she was a child and she was still on summer break, and so we knew that the vision was going to be poor, but her left eye kind of was holding her stable, that she could see pretty well without even needing any form of correction. She did have those residual specs that she was using just during the time of washout. You can see from a ocular health standpoint, the pre-treatment axial length. When she was referred to us, axial length had not been measured yet. So she had been in Ortho-K already for a year, but there was no measurement of axial length. And so we established a baseline measurement for her. You can see with that right eye being above a 26 millimeters for a 7-year-old, she's already at a high chance of having irreversible vision loss that we cannot come back from. So considering she has 10+ years of visual development, the need to treat is imperative. And so let me just make a change here. So here, oh, sorry, I'm going to go back one for a moment. Here are our baseline topographies. This is after the washout. You can see that high level of astigmatism, but we are with the rule. And I felt comfortable enough that these patterns at a 3-week mark are indicative of baseline. At that point, her mom was very anxious about getting her back into Ortho-K. So these were our baseline tear film independent topographies that were then put into the WAVE software in order to fabricate some lenses. So Dr. Chung, how about you walk us through the lenses that were designed for this patient?
Yeah, of course. Okay, so with many topographers and tomographers, you can have, your HVID pre-measured, but I like to measure it myself. So I just go into the iris image and do that, and then we can populate it into the WAVE software. And then once you click it open, we can click new design and then go ahead and put in our spectacle refraction. So for this patient, we have a -5 with 150 cell at axis 18. So HVID here is auto-populated from the device, but I measured 11.98. I mean, not a huge difference, but I like to keep that in mind when designing my lens. Target power, edge lift, and I'm happy with my 11.0 diameter here. And then I can go ahead and start the design. So generally, I do like to go a little bit smaller, just because I don't want it to hit the limbus. So I would scroll around, making sure all the meridians look appropriate. And then typically, I do find WAVE has steeper edges initially, especially for my higher myope. So I do just decrease the alignment zone a little bit, but otherwise, I let the software drive for itself. And then I inspect the lens, and in less than 60 seconds, I would say, I'm ready to order that lens. And then I just make sure all the parameters, the color, and everything is to my liking.
Okay, so let's take a look at these lenses on eye. You heard Dr. Chung mention about the, lost our videos there for a moment. You heard Dr. Chung mention about decreasing the edge lift in the design. So you can see there's a little bit of minimal edge lift along the horizontal meridian, a little excessive in the vertical, but overall get a pretty good bullseye pattern. I don't like to give anesthetics to my patients during the dispense visit because I don't want to falsely give them an idea of what the lenses will feel like when they are at home by themselves and screaming with their parent. Not good outcome for you. And so I don't put anesthetic. You can tell the patient's relatively comfortable as she's blinking back and forth with the lenses. Based on what the black dots are as well, we don't have really any type of rotation here. So I was happy with the fit, and I felt comfortable enough once we proceeded with our INR and making sure our patients had their kit ready to go for their first night. We send them off with their lenses. So the patient came back. This is a next morning fluorescein pattern. You can see that with the fluorescein on eye, we still have movement. I know there is minimal edge lift based on the fluorescein. I do have the patients close their eyes and hold it closed for a moment and kind of mimics what the lens would be doing in a sleep pattern. And I see what the lens, where it sits right upon blinking. And you can see that lens was up centrally and kind of dropped only after the blink was initiated. So I'm not concerned about an inferior fit here. When we proceed then, I didn't take topographies. The patient only had a few hours of sleep that night. So I had the patient continue to wear the lenses for a few nights, and they came back for a 3-day follow-up. I just want to go back for 1 second and discuss the on-eye aspect. So when a patient comes in the next morning, I think there's a mixed bag of clinical thought as to whether or not the patient needs to come in wearing the lens again. It's of little, if you're not going to make a change mainly in that first night, what value is it of having the parent bring a child in with lenses on eye? I think it's a good take-home point for you to make sure everything is looking good on eye. Remember, if they don't come back that morning wearing a lens, you'll never see that lens back on eye at all. It's also a good kind of ta-da moment if you are the one that takes off the lens in the office, because it's like, little Johnny was only seeing here last time, and now look, wow, like how much lines of vision that we have improved. So I find there's merit in doing that as well. But the next morning follow-up pattern really is your clinician preference. It's more so kind of to hit it home and make sure they're doing all the right steps in removal as well. So it gives you another chance to educate on the INR process. So at the 3-day follow-up, so that if you can recall, Dr. Chung mentioned the refractive power that the target was -5 and with a SIL of -150. So this is a high myop, more of a challenging case. The patient itself, after you can see how robust that reverse curve that has applied and the amount of treatment the patient's getting. I like to aim for at least a 3 to 4 millimeter treatment zone, and I want as uniform as possible of the flattening that I see in the central portion. I do like to use the numerics and these scales to get an idea of how much vision I'm expected to correct. And I can see I get about just over like almost 4 diopters, 4 3/4 diopters of correction in the right eye. Just over 3 1/4 diopters in the left. You can tell that the treatment area is not quite as dense and uniform, but we've got a nice reverse curve that's apparent here. And so the difference maps, preferably the tangential maps, tell us a good idea about where that lens is sitting overnight. The same patient at this point comes back now for a 3-month follow-up, and the treatment area looks almost the same, except for the fact that now we're getting over 5 diopters of refractive target. I'm happy, patient's happy, well-centered treatment zones, and these were with the initial fit lens. So first fit success in my book. The patient outcome, I'll show you some of the VAs in a moment, were better than the 20/40 right eye, 20/30 left eye she had originally come in with. So that was 2021. So 2022 now, this is fall of 2022. Just showing an example here of the 1-year follow-up. You can see that while we do have a very distinct reverse curve here, you can see that the treatment zone is quite not as dense, and using the same, always make sure that you're using the same apples to apples, the same scale, depending on the topographer that you're using. In this case, instead of getting over 5 units of correction, she's getting just over 3 units of correction. Well, nothing's changed. Obviously, question the parents about how many hours a night of sleep. Inspect the lenses always for any chips. I do find, especially in the high myopic patients, that these lenses do kind of warp and wear out over time. And so I'm a big proponent of changing at the 1-year mark, just to make sure we're keeping up with the best amount of treatment for that patient. So what exactly happened? So you hear me say August 2022, we're now August 23. So I've been following this patient for 2 years now, and starting off at a 7-year-old with over an axial length of 26. Great visual. We've taken, I know this is an excessive amount of axial length measurements, but remember I said this is the ultimate myopia control mom. So she really wanted to, like, this is what helped her sleep at night. She wanted to know that is my child's axial length stabilizing. And so while we've got a ways to go, and she's still got, herself over 10 years of visual development, we are doing our best to try to keep her as, so imagine if all of these dots come together. The dotted hash mark is showing the trajectory if we had done nothing at that moment in time. But you can imagine if that dotted hash mark was over here, if we had done no treatment, it would just have continued to go up beyond kind of what we have as our average axial length. Her left eye is coming within the more appropriate, I would say, plus or minus normal range. But the right eye has far exceeded that. Now, our goal is to see if we can keep this axial length below 27. At this moment in time, she started off at a certain value. The most we've got her right now, and what it's measured right here, I know this looks like it's dipped off a little bit, but this is 26.46, and we're around the same mark at the last check. So this to me is the best level of considering her age and where she started, the best form of control I've seen in one of my youngest patients. So I'm pretty happy with that. Patient's happy as well. Mom just reordered for her newest lens order. Yeah, I just expanded the scale here so you can really see, although there's multiple points, we're kind of hovering around a 26.6 mark up and down that point. So we don't ever, I mean, we're talking about like tenths of a millimeter change here, but we do know that that impacts the progression of myopia over time for our patients. So every tenth of a millimeter counts as much as we can to keep these kids as safe as possible from long-term vision loss. So prior to ordering our last lens, you can see there's a little bit of diff off in the prescription, and there is some residual myopic refraction in the when doing a manifest refraction for these patients. And so there was a base curve change. Centration was great. I didn't want to adjust any aspects of that fit, so just a base curve change was applied to see if we can get her just a little bit more of a refractive correction for both right and left eye. Now, this case I kind of wanted to discuss here, Dr. Chung, because, you know, I had this patient, this actually was just this week, and, you know, you talked about your candidacy for patients. Now, this is a patient that has, against the rule, astigmatism. It is quite apical. I wouldn't say it's gone limbus to limbus, but it's not only against rule astigmatism, but also we've got some refractive cell that's greater than corneal cell. Now, if we look at her axial length, so I did see her in 2022, axial length in 2022 in the right eye was 23.2 and 23.39 in the left eye. You can see now in 2023, we have a significant increase. Now we have a near over doubling of the prescription. I didn't put the values here, but the patient did come in September of 2022, and it already had increased 3/4 of a diopter in both eyes. But at that point, parents wanted to just go with single vision glasses. So after 2 visits of single vision glasses, 3rd visit just being last week, they're ready to proceed. And she's in extracurriculars. She does play tennis after school, and they're motivated. They want to do Ortho-K. Kind of, what do you think, Dr. Chung? Do you think we can fit this patient?
I definitely do not think this is an easy case, but if we just scroll over to the next slide here, we have the, I'm just going to pull it up. So if we kind of look at the candidate selection scale, if we look at their astigmatism, it is a little more challenging because it is against the rule. And then also it is more challenging because their astigmatism is almost as high as their spherical refraction. So usually in patients like that, we do see a bit more residual astigmatism even after we have the best fitted lens. I would say in these cases, like you said, the patient is very motivated, the parents are motivated. It is definitely worth a try. I would call it more towards a moderate to challenging case for that. But I think because of the motivation, as long as you set expectations accordingly, this could become a successful case.
Well, those are kind of where my thought process was as well, and I wanted to reiterate that to the patient's dad who came in today. So, I mean, we have to proceed with caution. The way that I prepared it with the parent is that we do have this astigmatism value that potentially can limit the results for her. In her spectacle lenses already, her left eye doesn't quite meet to 20/20. All other aspects of ocular health are great. So, I mean, we do already have set that expectation that seeing her best out of spectacles is somewhat limiting due to, let's say, unwanted aberrations. But for the Ortho-K process, that understands that we really won't know until we try. So from a kind of clinical tip, when incorporating a warranty period, I think this is not just for the warranty of the lens. You need to think about your chair time. And if you are going to proceed with an Ortho-K patient, you know, a parent, if it's not working in the first week, 2nd week, 3rd week, they might want out, and you have to be able to work that in. This case, I usually have a warranty period up until the first 3 weeks. after the 4th week, if they are just not happy anymore at that point, there's no refund, but we can work with them and put them into another type of myopia management treatment. And so I think, the goal is the same between the parent and the child themselves and myself, that we do want to slow down their myopia. So whether it be Ortho-K or something else we decide in the future, as long as you set the expectations and have the ability to be flexible on how you potentially shift their fees if they decide to change. I mean, all else is perfect and you continue and life is great, and that would be fantastic. But, I've had cases before where, everything looked great. The patients were very motivated. The parents are really motivated, and the kids just couldn't get the contact lenses in no matter how much they tried. And it ended up being a stressful aspect for the entire family towards the nighttime, which is something mom couldn't handle. And so we decided to switch them off into something else, but they were successful, their vision was great. And so you just have to be able to pivot when needed regarding these types of cases. And kind of that's our biggest take home here with our myopia management patients. You never know what's going to walk through the door, and they're each kind of a unique case. So with that, that concludes our presentation today, kind of on the clinical tips and the software-based design on how to manage your patients using orthokeratology. Any questions?
Great presentation, ladies. This was really, really informative. And we do have some good questions that have come in. Let's see where we'll start. Let's start off with a question about when you lift the alignment zone in WAVE. Sometimes patients will complain of this physical discomfort. Do you have any tips or recommendations that if you are lifting the alignment zone to improve the fit and then you make the comfort less, is there any tips you can give on helping with that problem?
I think it is a perfect balance in terms of how much you lift the alignment zone, because we do want that edge lift. Without it, we won't get any tear exchange. So I would say usually if we stay below the 20 microns line on the WAVE software, we're usually doing pretty good in terms of edge lift, because even normal Ortho-K's, diagnostic ones, they do have that edge lift, so it is necessary for it. But definitely go at your own pace and see what's the perfect number for you.
Excellent. Yeah, I know one of our colleagues, Ken Maller, has always told me when you have that comfort issue with changing alignment zones or any edge issue with comfort with the WAVE lenses, if you increase the edge thickness sometimes as much as 0.3, that actually can improve comfort, even though it's counterintuitive.
Yeah, for sure. That's also another way to do it.
So here's a question I knew we would get from someone, so I'm going to ask it. Can you do myopia control without having access to axial length measurement?
Dr. Ramdass, I'll let you take that one because I know you have a strong view on that.
Yeah, if we're talking specifically Ortho-K, I do believe that you would be at kind of a deficit to the patient and yourself if you don't have axial length. Now, it gives you the whole picture. Remember, Ortho-K, though, we had been doing for years prior to having axial length. So from a vision correction standpoint, we can definitely do it, but from a myopia management standpoint, you can definitely put those lenses on. You can monitor that patient. You can use your topography difference maps to assess over time. But the axial length kind of gives the bigger picture as to if you need to add adjunctive therapy. What if you're not getting enough control, that you have some residual refraction with your prescription, but you don't know if that's necessarily a fit issue, or maybe the patient just didn't sleep right. I find that axial length is a better measurement to show you as to how if that eye is increasing in size. So it's 100% possible you can do it. So I would never discourage somebody from doing Ortho-K on a child without having axial length, but if you're going to have a comprehensive myopia management approach, I do strongly believe that axial length is necessary.
Excellent answer. I think a lot of people use the analogy in glaucoma. Can you treat glaucoma if you don't have an OCT? And I think a lot of people would say, well, you can treat it, but today it's really the standard of care to not only do visual fields, but OCT in combination. And I think myopia management is very quickly getting to that point where axial length is standard of care also. So I think that's a really good question. And I think we get that question every single time that we do a webinar on this topic. So I have a question for both of you ladies regarding wave lens designs and orthokeratology in general. One of the issues that I get confronted with oftentimes, especially when a child will turn 16 and they start to drive, is all of a sudden they have glare that they didn't have the day before. And they start noticing that their night vision is not as good as it used to be, maybe because they never needed to drive at night and it was always there, but now they notice it more. What tips can you give as far as increasing the size of the treatment zone?
Yeah, so I think, like, let's say their treatment is still, just as good as it was before. They're still seeing what they needed to see. Usually in that case, it's just the pupil size that's causing the glare and halos. So a quick way that I like to check instead of going to change the whole lens design is just using a drop of Lumify to see if constricting the pupil a little bit will help. If in that case it does help, then I think increasing the optic zone size will help with that. So usually with kids, we like to use a smaller optic zone, such as like a 5.5 millimeter or a 6 millimeter. So we can just increase that by 0.2 to 0.5 millimeters larger, and that should help with the glare and halo issues.
Yeah, I think that's true. I think in the opposite situation, though, optic zone increasing may not always be as effective. And always, you got to be very careful when you change your optic zone, because it oftentimes will change your base curve without you seeing it, and it changes it typically steeper when you go to a larger optic zone. So you got to be sure to rectify that before reordering the lens also.
Yeah, for sure.
But excellent. And I think centration is everything. If the lenses weren't perfectly centered, but the patient was happy, and now they have glare, improving centration alone can sometimes just make everything better.
For sure.
All right, this is a long question. Can you go over the use of the S asphericity function for enhancing the design of myopia management in lower myopes?
Sorry, can you repeat that question?
Yes, I hope so. Can you go over the use of the S asphericity function in WAVE for enhancing the design of myopia management in low myopes? So what I'm pretty sure is being asked here is that, when you do a -1 myope or a -75 myope, you don't get much of a return zone, and oftentimes you're not getting much of a demand for the myopia control. Is there an asphericity functionality in the software that can help with those low myopic patients?
As of right now, like in terms of WAVE consultants, we do not recommend using the shape factor in terms of changing your lens into a more aspheric one. I know some people do have designs that kind of do it that way, but we still like to let the software drive for itself. And then if in that case it's still not creating the treatment we want, then maybe we could, outsource those. So as of right now, we do not recommend it. So therefore, I think if you wanted a little more on that subject, I think the Google group would be a good area to ask that question. And some people who have used that option will have a better answer for that.
Yeah, I think the Google group is a good, especially for off-label applications. The Google group can be very helpful for some people that have been using the software for decades. I agree. I've learned a lot from that group also on things that I didn't even know were possible to do with the software. One last question for both of you, and it has to do with choosing your diameter initially. And I know that every device, whether you use a Pentacam or MedMont or any topographer, each device measures either horizontal white to white or horizontal visible iris diameter differently. And I did notice that in that second patient you presented that I think you subtracted a whole millimeter from the horizontal visible white to white, and the lens still looked very big. Do you want to comment on how you guys determine your diameters depending on what device you're using?
Yeah, it really depends on the patient. Sometimes it looks a lot bigger in the horizontal white to white. That's why I like to physically measure the patient's iris based off of the image. Because that patient was previously in Ortho-Ks before, we just kind of kept it at that size for them. But generally for new patients to Ortho-K, I like to go 0.3 to 0.5, even up to 0.7 smaller if I'm worried about it touching the limbus of from the lens.
And when you manually measure, do you measure horizontally, vertically, or diagonally, or all of the above?
As many across the limbus I could get. So horizontally for sure, and then if I could get vertically, that would be perfect. I would get that. But usually I only am able to get diagonally, and then I get horizontally, and then I take the smaller number, and from that number I subtract the 0.5 to 0.7 millimeters.
Excellent. Well, the only other question I see here that we have time for is another glare question for high myopia. We talked about dealing with it for an older patient where you can compromise some of the myopia control when they have glare and halos, but this specific question is decreasing glare and flare in high myopia. Is there anything differently you would do for a patient with high myopia?
I would probably do the same thing with my Lumify technique. With high myopia, you're generating a lot more peripheral prescription as well, so they're bound to get glare. It's just how much of that can they handle. So I wouldn't change it too much in terms of how I approach the case.
And I have one question before we close. Your patient that had some residual astigmatism, it was only 0.75, and I'm not surprised that they didn't complain. But if, for example, that patient did complain of residual astigmatism, I know there are different methods of handling that. How would you handle residual astigmatism that a patient did complain about?
There are a few ways, just because WAVE is very customizable in the way they can, design the lens. So there is either base curve manipulation or like an oval optic zone. So I would say if that actually is one of your patients and you're still having issues with it, book with one of our consultants and we can walk you through it together, because it does get a little bit confusing, especially if there's any lens rotation.
Excellent. Well, thank you both for providing a ton of information. I'm going to go back and rewatch this one because it was so much there. This is really amazing. Thank you for your effort and your time tonight. And if we get any more questions, I will email them so we can answer anything that we didn't get answered. So thank you everyone for attending tonight, and I hope you all have a great evening.
Thank you.